So when I first got this topic, I looked at it and I kind of laughed because some days it's like, when do multiple comorbidities do not complicate pregnancies? Like every patient has multiple comorbidities. But unfortunately, that's the reality of our obstetrical population. This slide again shows maternal mortality in the United States between, whoops, let me go back.
Come on.
I got it. So you can see here between 1987 and 2013, there's a steady increase in maternal mortality in the United States, and that's continued in more recent years. And that again is in contrast to other countries, in like European countries, for example, where maternal mortality is decreasing. Every year, approximately 700 women die from pregnancy-related causes. And that may be a little bit of an underestimate because there are some deaths that aren't reported as pregnancy-related that probably are. The incidence is higher in certain populations. In certain minority populations, you have a 2 to 3-fold increased rate in Native American and African American women. It's actually about three times the rate in Caucasian women. And that's striking, and there's a lot of reasons for that, and probably I don't have the time for this to get into that in this talk. But what is interesting and what we need to pay attention to is that up to 60% of these deaths may be preventable, and that's a lot. We just look, and I kind of touched on this in a prior lecture, but if we look at the causes of maternal mortality, we have gotten better at treating a lot of the more traditional causes, particularly hemorrhage and pulmonary embolism. However, the incidence of cardiovascular disease has increased, and cardiovascular causes of maternal mortality have increased significantly. So why is that, and what's going on in the obstetrical population? And clearly, there's been some major changes. As I alluded to earlier, there are increasing pregnancy rates for women over 35 and especially over the age of 40. That's the only group really where the number of pregnancies is growing. Otherwise, the pregnancy rate in the United States is actually decreasing. Although we'll see with COVID what that does, because that might change some things next year. There are higher rates of hypertension and diabetes in the population in general, and in the obstetric population. And of course, you have the obesity epidemic that this country is going through, and that just adds to the morbidity. One other thing is that as I'm here in this cardiovascular conference about congenital heart disease, improvements in medical and surgical care have led to improved survival and better quality of life for many women with chronic illnesses. So these were women, and maybe decades ago, they weren't able to have the quality of life or weren't surviving to actually consider or get pregnant. And then there are some significant disparities in access to appropriate care and available resources that probably contribute to some of the disparities that I mentioned earlier. This just briefly looks at the incidence of looking at diabetes and hypertension, and you can see this in this triangle. The triangles here show the incidence of type 2 diabetes and how that's increasing. The slide below that shows gestational diabetes, which is also increasing significantly, particularly in the population over age 30. And then our incidence of hypertensive diseases in pregnancy has also increased significantly. So because of that, what we've also seen is a very significant increase in severe maternal morbidity. And I'll talk to you about what defines severe maternal morbidity in a second. But roughly 1 in 300 deliveries require admission to an ICU now. And this has increased nearly 200% between 1993 and 2014. Now, a lot of this has to do with hemorrhage and blood transfusions, but even if you exclude blood transfusions, there's roughly a 20% increase in severe maternal morbidity in that same time period. So what constitutes severe maternal morbidity? I mean, there's quite a list here. Many are cardiac-related causes. There's also several non-cardiac factors, risk factors here. But it's quite a list. And again, we're seeing more and more of this in our population. And so the idea here, what we're trying to do is to be more anticipatory rather than reactive. And so, so to make sure that patients are, getting the appropriate care, problems are being addressed in a timely manner and not allowed to develop into larger problems. And then, getting the patient to deliver and get the care in the right facility and with the right level of resources to support them. So there have been a number of screening tools developed to that end to help with trying to identify these patients ahead of time. The problem is critical illness still is less common in obstetrical patients than in other populations. So many of these tools, the sensitivity and the specificity aren't really good. They've used several vital sign-based screening tools. However, there's a lot of overlap between vital signs in pregnancy versus that in disease states. So these tests tend to have high false positive rates, and they tend to be ignored over time because of that. So again, probably a better approach is then to screen for comorbidities as they relate to severe maternal morbidity. So you want to identify these women either early in the antepartum period or during early labor, so you can prepare. So this is one particular tool that we're starting to use here at the Cleveland Clinic. It's called the Obstetric Co-Morbidity Index Score. And basically there are a number of maternal conditions here that are listed on the sheet, and they get a score for each one that a patient has. And you can see here, as your score increases, the risk for developing some type of severe maternal morbidity increases with that. So in this particular study that was done in 2019, a score of more than you can see here a score of more than 5 or 6 gives you about a 6% chance for significant morbidity. If that goes to 7 or 8, it's roughly 12%. And then greater than 9, you're up to 18%. So a significantly higher risk as you have more risk factors. So this is a kind of tool that can be used, and we're starting to utilize this here where you can kind of stratify risk and then you can anticipate issues. So what can we do with that? Well, we can assign, we can manage these patients, assign them to appropriate prenatal care providers so that these problems are addressed. So in obstetrics, we have nurse practitioners, midwives, obstetrician gynecologists, and then maternal fetal medicine specialists who all take care of pregnant women. So we, according to the risk, we can get them to the proper provider. And again, taking appropriate preventative measures and appropriate resources, trying to be more anticipatory instead of reactive. And then collaboration across specialties, which we've talked about a lot here. And then planning of delivery location, depending on, matching the resources with the level available at that site with the level of risk in the patient. And then again, regionalization of care, maternal transports, and transfer of prenatal care in an appropriate and timely manner. What does this mean? What are we seeing in terms of fetal considerations? Having more comorbidities, it does increase the risk for obstetrical complications as well, including miscarriage, fetal growth abnormalities, preeclampsia, and then iatrogenic preterm delivery, which, again, is preterm delivery that's not, mom doesn't go into labor, but we're having to deliver mom because of significant disease. And you can see the rate for that here are these diamonds, filled in diamonds, and it's steadily increasing in both singletons and in twin gestations. Also, the risks for C-section increase in these complicated pregnancies If you look at the C-section rate, the higher the comorbidity score, the C-section rate increases in those patients as well. As far as our management goes, again, close surveillance of maternal health. A lot of times that's in conjunction with a subspecialist from medical or surgical field, depending on what the underlying condition is. Serial assessment of the growth of the baby, amniotic fluid volume, and then some type of fetal surveillance at the end of the pregnancy. And then often, delivery has to be planned and timed, sometimes early. Now, this is another area that I wanted to just touch on that's coming, but what we know is that pregnancy outcomes are not just an isolated thing, and it plays a significant impact in a woman's health, and particularly her cardiovascular health going forward. So many pregnancy outcomes are strong predictors of cardiovascular disease later in life. So the example is preeclampsia and hypertensive disease is the one example. So if a woman develops preeclampsia, and particularly if it's preterm preeclampsia, and requires an early delivery, or she develops it in recurrent pregnancies, that significantly increases the risk for coronary artery disease and other hypertension later in life. So by studying, and the same is true for gestational diabetes, the same is true for spontaneous preterm delivery. So by taking a clear history of a woman's, taking a good obstetrical history can often provide clues as to what the patient might be at risk for later in life, and should be part of what primary care providers look at, because this prevents a great opportunity for preventative measures. The other area is gestational diabetes. So with gestational diabetes, if you have gestational diabetes in pregnancy, 10 years later, roughly 50% of patients will have type 2 diabetes. So again, there's this window of time where you can potentially take interventions and take measures to prevent the development of diabetes. And I think this is an area where a lot of healthcare needs to focus. And again, our approach here that we're sharing today about being collaborative probably needs to be expanded, not from obstetricians to primary care providers, to help prevent some of these outcomes. So in closing, just wanted to say that the incidence of comorbidities are increasing significantly in the obstetrical population, and pregnant women with multiple comorbidities have a higher risk for complications, both maternal and the fetal. Identification of these patients early is important for planning their care, and can help tremendously in trying to be anticipatory rather than being reactive. Using a structured tool such as the comorbidity index is very helpful and can allow timely transfer of these women to centers with appropriate resources and capabilities. And again, as I've said before, a multifaceted approach is the way to go to optimize both maternal and fetal outcomes. Thank you very much.